Bwrdd, everybody, croeso, welcome. I'd particularly like to welcome Hashim Samia, the Vice Chair of our Board Advisory Group, and Hazel Lloyd-Lubran, who's the new Chair of our Stakeholder Reference Group, to their first meeting. As we all know, this has been an exceptionally challenging period in the history of the NHS, and for the past 9 months, we've all been doing everything we can to rise to the challenge of COVID and care for all our patients. Currently, we have more patients with COVID in our hospitals than we did at the peak of the first wave. We are much more prepared, but there are more challenges this time. We've rightly restarted routine operations. Our ability to do as much as before is greatly restricted because of social distancing, PPE and infection control measures. And we have the added demands that winter brings. And our workforce, including all our teams who are here today, are understandably tired and weary. At the start of our board meeting, I'd like to take the opportunity to thank our Chief Executive, Steve, and all his executive team for their outstanding leadership, and to them and every member of staff in Hywel Dda for their dedication, their sacrifice and their care. Thankfully, there is light at the end of this tunnel. It's wonderful we now have vaccines, and as soon as they are approved by the regulators, we will embark on the biggest vaccination exercise in the history of the NHS. This brings its own logistical and workforce challenges, which we will do everything we can to overcome. I'd also like to take the opportunity at the beginning of our board meeting to thank the people of Carmarthenshire, Ceredigion and Pembrokeshire for following the rules and keeping our infection rates low and saving lives in West Wales. Until 70% of us have been vaccinated, we must all continue to follow those rules and keep this virus at bay. Today at our meeting, I'd be grateful if we could be concise in our questions, in our presentations, and assume that all our papers have been read. And this will free up our executive colleagues to get on with the huge tasks that face them. Just a housekeeping piece of information. We are all doing this virtually, and we generally use the hand symbol when we wish to come in. This doesn't work on a live broadcast, so if you could please use the message bar and tell us that you'd like to speak, or indeed if you just wish to give us a message, we'll ensure that's read out. So thank you everybody, and I'm going to go straight in to the board meeting. Do we have any apologies for absence?
No apologies for absence, Chair.
Thank you. Any declaration of interests? Okay, thank you. We'll now go to the minutes of the public meeting held on the 24th of September. Are there any matters that people wish to raise about inaccuracies? Can I see the message bar on the big screen, or are you going to pick this up for me?
Can you put the chat bar up? We can read the messages.
Thank you.
Thank you. Simon Hancock, Chair, has got a declaration of interest if Bluestone Field Hospital is discussed, and that's declared in our formal register of interest.
Okay, thank you. I will assume from the silence that there are no inaccuracies in the minutes, and I'd be grateful if everyone can confirm that they are happy to approve the minutes. Thanks. I'll now go to my report. I don't intend to read them through my report, but there's some excellent news in there. I particularly like to draw attention to the award winning of our teams and the Chairs Awards to the incredible work that people are doing. And I'd like to congratulate our Vice Chair, Judith, for being appointed as the Chair of the Regional Partnership Board. Would anybody like to ask any questions on my report? We can see the chat bar now. Judith, please come in.
Thank you, Chair. First of all, thank you for those congratulations, but I would like to echo everything you've said in respect of the Chief Executive, the executive team and all our staff. In terms of your report, I would also like to draw particular attention to the Celebrating Assess on page 5 in the Advancing Healthcare Awards, the success of the Early Intervention Psychosis team They won a NHS Wales Award last year, so it's really pleasing to see that this has been recognised in a UK-wide award, and I think I'd like to add my congratulations to that team. Thank you.
Thanks, Judith, and totally agree with that. A fantastic achievement. And Mike, another one of our IMs, has come in saying a massive well done to our directors. Any other questions on the report? Okay, thank you. I'm now going to go on to the governance report. As you know, during the first wave of the pandemic, we streamlined our governance to enable people to keep us safe, to keep us open and transparent to the public, but also to enable everybody to get on with the huge task that the virus brought. We're going to do the same with our second wave. Joe, do you have anything to add to the paper?
Sorry, Chicken, just going back onto your paper, we just need to get the board to ratify the use of chair. I apologise.
No, excuse me. That's my mistake. Are the board happy to accept the recommendations at the end of my report, in particular to ratify Chair's action?
And just to, on the Chair's action, Chair, just to conclude, the Director of Finance has contacted Welsh Government in regards to the Leeds Park Scarlets, and that side of it now is covered. We don't need, because of the VAT levels, we don't need approval, so we're okay to press ahead with that one. And I know the our conversations with the Director of Ops and Chief Executive about when that lease will conclude. So just to conclude for members, that's all been taken forward.
Thanks, Joe. And thank you, everyone. I can see your agreement to ratify Chair's action. Thank you. And now go on to the governance paper. Joe, do you have anything to add to the paper?
Just to say, Chair, really, it's an update on where we are. We have streamlined as far as possibly safe now our committee structure as we're now in the second wave of the pandemic. And it's just really for the public and for our members just to approve that they're happy with those changes that were made. I guess the only one to call out, which the Chair of the Audit Committee may wish to pick up in his own report, is the issue with the outstanding number of audit recommendations we have now and how we're going to take those forward. But I'm assuming the Chair will pick that up through his reports. It's just for approval really of the changes we've made, Chair.
Thanks, Joe. Paul, would you like to pick that up in your report, or would you like to pick it up now?
Sorry, I'll pick that up in the report, Chair, if that's okay.
Grand, thank you. And I'd just also like to assure any public who are listening that we had an excellent report from Audit Wales about our governance during the first wave of the pandemic. I think there's one issue that has been raised as well is, and we've gone virtual, and that's thank you very much for our IT team for enabling that to happen, both within our services and within our governance. But I think we all need to resist having too many of these virtual meetings because they are easier, but people, it can take up too much time, and people really need to get on with the job and resist the temptation. And I think it's something that the board secretary raised. We are streamlining our governance, but we also need to streamline some of the meetings that happen below governance. And I'd like everyone really to take that into consideration. So the board's happy to accept the recommendations in the governance report. And Judith says excellent words from the board secretary and the team. I absolutely agree. Amazing. So thanks to everybody for agreeing. Next is the report of the Chief Executive. Over to you.
Thank you, Chair. It's a succinct report, so I will be succinct on this because most of my update is actually in the COVID update paper later on the agenda. Just a couple of things I would want to just mention, particularly to highlight the reduction in our escalation status from targeted intervention to enhanced monitoring. Just a recognition of that. That's 5 years of work across the organisation that has resulted in that. And also a reflection of the comprehensive COVID response that our teams have led here in West Wales. I guess if this was more normal times, whatever that might be, this would have had probably more external impact, particularly as there was so much interest as we went into targeted intervention. But I am hugely proud of the work that all of our staff have done to make this happen. Of course, we have challenges remaining as set out by Welsh Government and in my report, particularly around returning to financial balance and our capacity for planning. And they're both in our plan moving forward about how we're going to address those things. I'm also asking in the report for a bit of board forbearance on reviewing our major incident plan, really for two reasons. One is a very practical one, that we are in the middle of what feels like an ongoing major incident, and therefore to be reviewing it would be a challenge, but also because there's so much learning going on about how we manage during COVID that we'd like to reflect that in the review in due course. And of course that learning is still ongoing as we are in the middle of our sort of second wave of infections. And then finally, just to acknowledge publicly and thank Karen Miles as she retires after many, many years of dedication to the NHS, and also the actions and support she gave in the early stages of the pandemic response. And I just wanted to wish her very well for the future.
Thank you, Steve. Are there any questions from board members? Just indicate in the message bar if you'd like to ask a question. Okay, as well as the recommendations which are within the report, we'd also like board approval for quarter 3 and 4.
Well,
Oh, sorry, that's on COVID.
Yeah,
that's fine. That's grand. Board happy to accept the recommendations.
Paul, can I ask?
Paul, please come in.
Yeah, sorry, my typing is not that quick. Yeah, Steve, could you, obviously we've had some discussions regarding the Parker Scarlet situation and the field hospitals generally. Can you confirm what the likely timescale is for us being able to conclude or leave Parker Scarlet and cease to need that facility?
I think it's a difficult question to answer. There's a sort of contractual angle to that, which I'll ask Hugh to pick up. But you know, the key issue is how this pandemic evolves over the coming months. And right now, you know, we are, as the chair mentioned, seeing high demand, of course, overlaid with our normal winter period. So for the foreseeable future, we need to keep the contingency that is all of our field hospitals ready to go. Clearly in the spring, particularly as the vaccines, assuming that they pass their safety and regulatory hurdles, we'll start to change that position. But I think for now, we need to keep all of that provision ready should we need it, particularly in January and February. Hugh, I don't know whether it might be worth just covering the contractual elements of the timescales we've signed up to.
Yes, thank you. So the timescales would take us up to May by the time we conclude on the remedial works that would be needed. So there's a 6-week period of remedial works that might be necessary, but there is a break clause that we can enact at any point after Christmas, so that gives us additional flexibility should we be able to terminate the contract earlier and reduce therefore the financial consequence.
Thank you. Are you happy with that, Paul? Thank you very much. Are there any other questions? There's a comment from Donna. Thank you, Donna. The CHC would also like to thank Karen for her work with the CHC over the years. Thanks, I'm sure she'll appreciate that. Any other questions? Okay, are the board happy to accept the recommendations on the CEO's report? Many thanks. If we go now into the next item on the agenda, which is the report of the Audit and Risk Assurance Committee. So that's you.
Yes, thank you, Chair. As you'll see from the report, we've highlighted 3 things to be drawn to the board's attention. One for consideration and one simply as a matter of concern, or 2 other as a matter of concern. The position with the partnership governance is set out in the report, and I think the issue perhaps is related to some extent. These are some issues which are not necessarily within the direct control of the health board and rely on work with our partners, and to highlight that issue, and obviously the appointment of Judith as chair of the RPB will perhaps help to take those issues forward. The 2 other items are issues which are long-standing issues for the health board, and as it sets out in the report, have been adversely affected by the pandemic, but they are nevertheless issues, I think, which are of concern and which need to be addressed as soon as circumstances permit. And that sort of takes me as well, I think, to the issue which is highlighted in the good governance report, and the number of recommendations which are now past their 6 month, that were more than 6 months overdue. We've got 123 out of 149, and clearly as time goes by, the likelihood is that that number will increase. It is an issue which is being discussed in the in ARAC, and I think that we recognise that there's a balance to be struck between the need to make progress with these issues and the obvious pressures which the organisation is under at the moment. But it's really, I think, to highlight that there will need to be what is effectively a recovery plan, so how we can address the outstanding recommendations in a timely fashion, and to look at what may be within those outstanding recommendations which are of the highest priority and perhaps have the greatest impact on patient safety and patient experience.
Absolutely fantastic. Any of the executive would kindly respond to that.
I'm happy to come in generally, and then others might. But I think thanks to the committee for highlighting it. I think you're absolutely right. There's many things that need to be in our recovery plan, and one of them is to ensure that we do and make progress on all of those outstanding audits. So, I think you've got the commitment of the execs, Paul, to be able to do that and to focus on that as we start to come out of the other side of this, alongside all of the other recovery actions we need to take.
Well, from what you're saying, it would help if there was a prioritisation plan at some stage goes to your committee.
I think that's right, yes, and I've had some discussions in the last 24 hours with the head of internal audit as to how we might seek to identify some of those, effectively an audit of audit recommendations, to see which ones we could look to prioritise, and that might help to feed into that discussion.
Shall I pick that action up, Chair?
Yes,
I'm happy to lead the prioritisation with the execs and work with head of internal audit and the chair of ARAC, if that will help and bring something back to the an update to the December ARAC. It might not be a finished product, but at least we can assure the committee that the work's in progress.
That's excellent. And in view of all the other things you're doing, maybe December might be a bit soon, maybe the one after, to be reasonable. But if Joe leads that, would you be happy with?
I'm perfectly happy with that, and be very grateful to Jo for all the help she provides and has provided throughout the last 6 months to me in this role. So yeah, I think that would be really good, and I think it really is the art of the possible.
Yes.
It's not a case of wanting to put undue pressure or undue expectations. I think it's just to be in a position to have a mature discussion about what's possible, really.
So many thanks for that. And in relation to the concern about the governance arrangements, I totally agree. Having Gyhoeddus as the chair of the Regional Partnership Board, I think that will really drive that forward. No pressure, Gyhoeddus. I think you've only been chair a few weeks, so but we'll get there. Many thanks. If I can then, any other issues, Paul, at all? No. Okay. If we go on to the update from our transformation steering group.
Yeah, thank you, Chair. I can be relatively brief again because I think the paper explains itself. But just to say that the Transformation Steering Group continues to develop. We've got new members, as I pointed out there, bringing their wisdom and experience and insight to that group. And it remains a really challenging and interesting discussion that is had there. And of course, we recorded also that all board members can see. This is the first time actually we've brought 2 new proposed planning objectives that have been through the whole process now. From the clusters through to the Transformation Steering Group and the Strategy Enabling Group, and they're here really for ratification for today, and they will be added to the existing planning objectives that we signed off as a board in September. Yeah, I look forward to further updates coming through from the Transformation Steering Group as we develop its role.
Thank you, Steve. I'm going to bring in members. There's 2 questions on the message bar. Dan, could you come in first, and then Maynard, please? I think you might be on mute, Della. Oh, you've got IT issues. Della, I'll ask you a question for you then. It's on the message bar. If we could press the see more. It says, really, Transformation Steering Group update and asthma service. Is this only for adults? As figures suggest, 1 in 10 children suffer asthma.
I think by recollection, is, and Jill coming on this, is that the cluster initiative is based, was not limited by age.
Okay.
So I assume that all age groups would benefit from this.
Maynard?
Hi, Chair. Thank you for this. Steve, could you give us some background of the two new attendance members and what they are bringing to the table at the TSG, please?
Yeah, of course. Thanks, Maynard. So very delighted to have Baroness Rennie Fritchie join us recently. Rennie's got a long and illustrious career in the NHS, spanning many years. She was a personal hero of mine when I was a very junior member of staff in the South West, and she was the chair of the South West Regional Health Authority. And more recently, in the last few years, she's providing mentoring support to a number of the exec team, including myself, actually. And she's got a huge amount of experience in sort of social models for health, in that sort of whole focus around human beings and how you make services wrap around human beings. And of course, as a member of the House of Lords, also has fantastic contacts that we are shamelessly looking to use as we start to think about our transformation experience going forward. Caroline Gullery, another fantastic addition. We spent a lot of time during our work on the Transforming Clinical Services strategy, looking at around the world at different health systems. And one of the key ones we looked at was the Canterbury system in New Zealand, which, following their earthquake, completely transformed the way that they provided care to a much more community-based, out-of-hospital service. One of the best in the world, actually, one of the strongest track records. And Caroline Gullery was the Chief Operating Officer for the organisation that secured that, and her background was actually in community, and she was the architect of that. So she's working alongside us both with the Lightfoot work we're doing, because the data-driven approach she used has proved its worth down in New Zealand, but also because she's bringing that wealth of experience about how we can shift to that community model that we've set out in our strategy going forward. So two really strong additions to the team. It doesn't make it easy to chair, I have to say, but really good, really challenging discussions.
Thanks, Steve. And I'd really recommend to members to have a look at some of the live recordings. And I'd like to thank Steve for sharing this and taking this forward, particularly in face of the challenges that we have in everyday work, because it is the way that we actually will improve and grow as an organisation and serve our population better. Thank you. Is there any other questions on this report?
Councillor Hancock first.
Simon?
Thank you, Chair. I just wanted to ask in respect of the social prescribing, what's been the learning from the cluster pilot, and have we now developed a social prescribing evaluation methodology, which will be essential if we're to roll this out across the health board area?
Yeah, good question, Simon. I think there is certainly more to do on the evaluation framework. This was a cluster-led pilot, which did demonstrate particularly qualitative improvement. I think as we roll this out, we will want to see what the wider impact will be, because the clusters themselves, I think, acknowledged at the time that they hadn't looked at the whole kind of impact on the pathway. And to be fair to them, because of the scale of it, it was probably quite difficult to see whether that changed demand for hospital care and other health and social care services. So there is a need to build an evaluation framework around this in the longer term. I think the view of both SEG and TSG was that there are so many places around the UK and indeed internationally now that are using these sorts of systems, and the value for money should be demonstrable from this, that this was something worth trying on a much wider basis than we've ever tried before. But we will evaluate it as we go along, and of course with all of our planning objectives, I think as we discussed in September board, some of these may not have the impact that we hope they will have, but that's kind of part of the point of trying new things, I guess. So hopefully that sort of reassures you that there was certainly qualitative benefit. In terms of quantity, I think we've yet to build that case, but we'll do that as part of this rollout.
Thank you. And Della has put, unfortunately, Della has audio problems today, but she has put in the message bar, really helpful, that's Ray Social Prescribing, Swansea University Connect have looked at it in respect of children and young people. So it'd be really good to pick that up. So thank you. The board's happy to approve the two new planning objectives with regards to the GP cluster projects. And I think this is really important because it's so important that we work more closely with our GPs and our GP clusters. And it was their projects that they brought to us earlier in the year. And to take these forward, I think is really important on a number of levels. And also, are we happy to approve the amendment to the executive lead of specified planning objectives? Thank you. So I'm now going to go on to the major infrastructure programme business case. I'm going to ask Professor John Gannon first because this did go to his committee. Any views and on the scrutiny that happened there? John?
Thank you, Chair. So we did review and discuss this programme business case, and we were happy to recommend to board that we would support that. There were a number of questions and comments that I would wish to raise at board, particularly the programme business case talks about how we're going to manage our existing estate. And I guess the question is, are we clear about the implications of this programme business case in terms of business continuity on our existing services and our existing estate provision? And have we planned for that also?
Thanks, John. So I'm going to bring Andrew in now, please, for the paper and to address what was raised via John's committee.
Okay, thanks, Chair, and thank you, John, for the question, which I'll pick up. Just checking you can hear me.
Yes, thank you. We can.
The screen is telling me I might be on mute. That was all. So I just wanted to check that. Sorry. I think the key points really to flag. Obviously, the board will be aware from previous conversations that we have a significant estate backlog, maintenance backlog in terms of work. That's partly down to the age and condition of the estate, and we've been in discussion with Welsh Government for some time around a more strategic approach to dealing with that challenge. Part of the issue has been that the sum of money we have to allocate to this type of work is contained in the discretionary capital sum, which is a relatively small sum of money for the extent of the work that we need to undertake. On agreement of the Health Board strategy a couple of years ago, Welsh Government indicated that the programme business case should be developed not just in the context of our estates backlog, but also to take into account the strategic direction the Health Board was now setting and had discussed in terms of its four main sites to which this case refers. So there are effectively two aspects to the business case and the submission that will be going to Welsh Government. The first request identifies a work programme and sets out a cost of £118 million that will be required to maintain and repurpose Glan, Gwilly and Widdybush as in line with our strategic plan over the next 8 years to 2027-28, and then a further £128 million requirement to maintain and bring up to standard over that period and beyond the estate at Prince Philip and Brongleis, again in accordance with our strategic case, strategic plan for the Health Board. Obviously we're asking for agreement for the board today to submit that business case to Welsh Government for scrutiny. It's been developed with them over time, so they're very well aware of a lot of the content and detail within it. I think in terms of obviously there is going to, I mean, the work that we're talking about here is work that we need to undertake anyway, and as part of our estates backlog plan, we are regularly in the process of managing the refurbishment and upgrade of areas through our sites, even at times when we're trying to deliver services in simultaneously as well. Obviously, the detail of that we will need to set out as we get approval and we work through the implementation of the business case to be able to give you assurance, John, through PPAC as to what impacts, if any, there will be.
Thank you.
Thank you, Chair.
Thank you, John. We have a question from Paul. What is the timescale for consideration of the business case by Welsh Government?
It's a process that Welsh Government run. It's a scrutiny process. It goes around all of their various policy leads in Welsh Government, and they all consider it and feedback. It often depends on the size and complexity of the case. Obviously, this is a case they're expecting, so hopefully they will be ready and geared up to help provide that scrutiny as quickly as possible. But I think just like we are feeling the impact of COVID on our everyday work and our routine work, we shouldn't forget that Welsh Government are also obviously managing at a national level the pandemic situation across Wales. So there may be, and we'll have staff deployed into different aspects and roles. So there may be some that the normal process may take a little bit longer to complete. But I think, as Hugh's put in the chat bar, we do have regular capital resource meetings with Welsh Government where we will keep abreast with them of the progress they're making with the scrutiny. And I'm sure, knowing from past roles and when I worked there, I know that through those conversations they will give early indication of any issues that they see or that are coming through from their early scrutiny. So hopefully that will be an ongoing conversation and process to the point of getting the approval.
Thanks, Andrew. Are there any more questions? I think it's really important as this. Mandy, did you want to come in? No? Okay, no problem. I'm sure it's really, I think it's really important as this continues and goes through the Welsh Government process that we also continue to communicate with our public about the results and what it actually means, and so that you know it's close to their hearts. Obviously, it's their hospitals, their estate, and so if we could keep that communication line as this progresses, similarly with our stakeholders. So thank you. Please do.
It was sort of tangential to that, but sort of connected around how we keep in contact with the public. We will bring a paper back in January to board around the new hospital build.
Okay.
Just give an update on timescales and where we are with the process. I'm conscious it's not been in the public domain.
That's super, thank you. And thanks, Professor Gammon, for the scrutiny of the business case in your committee. Sorry, I've got Helen Williams there on the chat bar. The CHC have received a number of concerns from patients. You'll have to make it more.
The CHC have received a number of concerns from patients where they have to travel for a scan as certain scanners have broken down. Are there any plans to take these forward separately?
Yes, the issue of some of our ageing radiology equipment is an item on the corporate risk register, and it's something that we are regularly reviewing and looking at. We've obviously recently secured the CT pod at Glangwili that has just become operational in the last couple of weeks, which will help to manage some of the resilience around CT scanning, both for us and also Swansea Bay University Health Board over the coming period. There are discussions at a national level, I know, around how we may be able to increase resilience around imaging and capacity, particularly in light of the impact COVID has had on capacity and waiting times. Which is a conversation that's being considered by Welsh Government at the moment, and we have plans also locally to continue the discussion with Welsh Government around how we business cases to replace our ageing equipment that needs replacement.
And I think that question may have been from Mansell, because there is a message from Helen to say that it's actually Mansell. So Mansell is the chair of the CHC, so thank you. Phil, you'd like to come in to make a comment?
It was just a brief comment, probably relates to what Steve just said, that I suppose this paper demonstrates what is one of the really key drivers for our strategy that we agreed in 2018, as Andrew's alluded to. And that any work that we do on the current hospital infrastructure is necessary, but not sufficient. and it does have a real impact on both our public and our staff. And so I suppose the progress that we make on the business case, the new hospital and new repurposing of the hospitals as we agreed in 2018 is going to be really really important, so we can provide that high quality care.
And Hugh also says that he will pick up the capital resource availability in his finance report. So many thanks. Are the board happy to accept the recommendation and approve the business case to go to Welsh Government? Yes, thank you. Thanks very much. We're going on now to the next item on the agenda. Mandy, it's the Improving Patient Experience report.
Thank you, Chair. Yes, I'm delighted to be able to present this report to board. I think each time we produce the report, we try to add something extra into the report that gives a sense of the contribution, the value that our staff are adding to patient care and experience. But each time we also are trying to focus on the impact that some of the things that we could do better are having on our patients as well. And I'd particularly like to reflect upon the stories that have been presented within the report. I don't know about you, but I certainly found them quite emotional to actually watch. But I think, again, what it demonstrates is the value of the family liaison officers in supporting the connectedness and communication challenges that we're dealing with currently during the COVID pandemic. And whilst I'm talking about the family liaison officers, what I would say is that we're currently in the process of trying to recruit some further family liaison officers, our flows as we lovingly call them, because obviously those that started with us at in the beginning of the pandemic have moved on, some have gone back to their employment, etc. So we're currently in the process of doing that. And certainly strategically, we're in conversation about what do we do? What does a post-COVID world look like in the context of communication and supporting that connectedness, particularly as we will have to, when we go forward, think about how we're going to support and managing hospital visiting across all of our sites. So that is something that is absolutely foremost in our minds at the moment. What I am clear about is that the extent of the flow, the family liaison officer activity, we need to continue, but we do need to make sure that it fits within the overarching framework of the staffing resource that we need within all of our areas. The report does call out that communication is one of our biggest issues. So again, whilst I've said that obviously the flows will play an important part in what the future looks like, I think that the work that we're doing around the command centre and transferring it into a communications hub is certainly something that we're going to try to drive forward and enhance further the communication work. And what I will say is that we have set up a steering group to actually help us take that work forward. And we have an initial focus on orthopaedic waiting lists. So that is our proof of concept, our testing ground, if you like, for how we can make sure that we further improve our communication with patients, particularly those that are on the waiting list, which, as was called out in the report, is one of the themes that has emerged from the complaints that we've received. In terms of operational response to our communication challenges, I'm having continued dialogue with the heads of nursing, the general managers and our hospital clinical directors to look at what more can we do, because I think that corporately we're doing absolutely everything that we can. We're focusing around customer skills training, we're using patient stories, we're trying to make sure that staff have got real-time access to feedback and communication through the various systems that we've put in place. And actually stories are probably the most impactful and powerful way in which we can share the feedback from our patients, as we've seen through the stories delivered in this report. The only part that I will then, before I finish, just call out is in section 5. I think it's page 7 on our bundle of the reports, is linking into the compliments and the feedback and how that has been married against the health board values. And I think what is really helpful is that whilst I'd like them all to be demonstrating full impact, the compassion, caring, kindness and respect coming out as the top 4 values that people have recognised, which certainly fits with our objectives and our aspiration as an organisation. So I won't say more than that, but I'm happy to take questions.
Thank you, Mandy. And there's a lot of messages in the bar supporting the family liaison officers, and Donna says about the All Wales survey as well. And I wonder when in post-COVID, when we are considering their role and their continuation, we could also consider an extension of that role to look at discharge planning, as they have these relationships, established a relationship with patients, and that's similar to the Pink Army. Elsewhere, if we can't have just purely family liaison. Della is asking a question, and I'm going to ask Joe to read it because the message on the big screen won't show me the whole question.
So Della's question, Chair, is in regards to communication, can you also indicate how the service can assist with relatives with hearing and sight difficulties to keep them informed of the patient's care, especially if some of our elderly patients cannot use iPads or indeed have mobile devices at home? And Anna Lewis is the chair after as well. Question.
Shall I respond now, or would you like Anna to come in first?
Carry on, Mandy.
Yeah, so in terms of patients with sensory deficits, we are looking at what more can we do, and I know that certainly it's been exaggerated and made all the much more challenging, particularly for those who are hard of hearing, unable to hear, communicate effectively, who rely upon lip reading, particularly as we're wearing masks. But going forward, looking at how we make sure that we've got opportunities for whether it's our family liaison officers or in fact other members of staff to undertake sign language learning, and looking at a whole host of visual opportunities to be able to support communication as well. So I think there's nothing there's nothing not on the table that we're trying to consider, and I think I certainly work with a very creative team who will, I'm sure, come up with some solutions to help address some of those issues.
Thank you, ma'am. I'm going to bring Anna in now.
Thank you, Chair, and just to reflect the fantastic progress in the reporting of our patient experience information to the board, Mandy, I think your team are doing a great job. Each time we see it, it gets that one bit better. But I would like to pick up a question about communication, please, and I raised last time the relationship that often exists between staff burnout and a tail off in the quality of communication in real time with patients in the clinical environment. And I'm aware that we're doing lots of things to try to support staff through this really impossibly difficult period that we're going through. But I wondered beyond that whether we have any sort of systematic way of taking the temperature in the organisation at a team or department level that allows us to be proactive in picking up any sort of alarm bells really around any particular areas that are really starting to struggle with staff burnout at a team or department level.
So I don't know whether Lisa might want to come in, because actually Lisa's team has been doing an awful lot of work around supporting our staff during what is an extremely challenging period. But certainly the connectedness that certainly I and the assistant directors and others are trying to have with the frontline staff, together with, and I know that Phil as medical director and Steve have been out and about, they've been engaging and talking to staff, and that very real contact is helping us gather feedback. And I know that the chair herself goes out and speaks to staff as well. All of that does come back in. We have a variety of mechanisms, particularly around the emotional support and well-being, looking at how Suzanne Tarrant and her team are supporting staff as well. But I don't know whether Lisa would like to come in and offer any feedback on that as well.
Shall I just come in? I think you've said a lot of it, Mandy. So Suzanne Tarrant's team do engage with individuals, do engage with managers, and also then put support programs in place for teams. She's very closely linked in with Christine Davis, our head of OD. So between the OD interventions and the staff psychological wellbeing support, it is something that we are providing on a regular basis. We have increased our staff psychological wellbeing team in the last month as well, so we have got more people out there supporting our staff on each of the sites.
I'm going to ask Steve to come in as well, because he's also taken a leadership role in this particular area.
Yeah, I was going to say more in the COVID paper, but I think probably the biggest concern going into the period we're now in and through into January and February is that sense of strain and exhaustion. And the chair and I actually met with Suzanne Tarrant earlier this week just to discuss what she was picking up. I think what she's feeling is that alongside the kind of individual stresses and strains, she's now seeing that teams themselves are kind of reaching out and asking for support. We've had discussions about what more we can do to really help support that, particularly now. I mean, it does feel quite strained at the moment, but I've got particular concerns about January and February, when we may be dealing with both, our normal winter busiest time, potential ongoing COVID peak, and a mass vaccination campaign that's going to be pulling us in a number of different directions. So we continue to kind of push ourselves on what we can do to support our staff out there, and the chair and I sort of taking a personal interest in leadership role in that. But we've got to continue to test ourselves. I think that my biggest concern is just helping staff now who are right in the middle of this to be able to get through the next few months, whilst knowing that in the spring, there is definitely going to be an improvement in this.
Thank you. Helen, I wonder if Jo could bring it out, please.
Sorry,
it's going to be from Marcel.
Yeah. Can I bring to the attention of the board the All Wales CHC report of Feeling Forgotten, as this outlines the concerns of patients that have not heard anything or very little regarding diagnostic tests or appointments since the first lockdown in March. It was sent to the CEO's office yesterday as well.
Thanks, Marcel. And I'd like to ask either Steve or the executive lead. We did agree as a board that we would contact all patients. It's a huge growing challenge, because we now unfortunately have just over 20,000 people who are awaiting treatment because of the impact of the pandemic. But I think I'd like it to come back to board actually where we are in that communication. So I don't know who's taking the lead on that. Mandy, could you come back on that, please?
Yeah, absolutely. And I think the whole approach that we're trying to design as one of the board's planning objectives around the communication hub is certainly going to help address this going forward. But I will certainly link in with Mansell and colleagues within the CHC to provide a more formal response to the report. So I'll pick that up if I may.
Thanks, Mandy. And if it could come to board as well, so that we are cited on the progress. It ties in with the patient experience report, and their communication is always high, always, and it's always high on when things are going well. It's it's a good thing as well, but I think it's important that we're cited as to the progress on that. Andrew, you'd like to come in?
Yes, it was just to add and inform the board that I believe the scheduled care team wrote to all patients on waiting lists at the beginning of November to give them an update on where we were and what the issues and some of the challenges we were trying to overcome, and give them an update on their pathway. So hopefully members of the public that are waiting will have received that correspondence.
Thanks, Andrew. And Steve and I saw that for those patients, and also the links in there for information and where to go to should they need to have further medical assistance. So thank you for that. Are there any other questions on the report? Can I reiterate what members have said, if I may? It's really growing, this report, and it's so rich and so important, particularly now, because we don't have a patient story at the beginning of board. And this report brings the patient story, the patient voice alive. And as you said, Mandy, the videos and the stories at the beginning were incredibly moving and incredibly compassionate. and it's it's essential that the voice of our patients is heard at this board, and that report really enables that to happen. So thank you very much, and if you could pass that on to the team, please. So the board's happy to accept the recommendation. Thank you. If I go on then now to the COVID-19 report, over to you, Steve.
Yeah, thank you, Chair. And there's again a great deal of detail there that I don't expect members to have entirely read, but just gives a sense of the scale and scope of what we are addressing at the moment. The paper is as it stands. Every time you write these papers, they go out of date pretty quickly, and I think it's got to recognise that the pandemic itself, and indeed our response to it, continues to be fast moving and quite a fluid situation. So there may be updates that independent members may want from individual execs that we can pick up after I've finished, just to get a sense of the very latest. I guess what I want to say, we've covered some of this actually in a number of the papers previously. It does feel at the moment from where we stand today that our infection rates are uncomfortably high. And of course, we're seeing clusters out in our communities, most recently the Cardigan cluster, which is impacted. Since writing the report, the infection rates across the health board now stand on average at 152 per 100,000, which is higher than I wrote just a week or so ago. And actually in every part of the health board now, we're over 100 per 100,000, which a while ago would have seemed extremely high by comparison. We're still below the Welsh average, but I think that whole average has continued to grow despite the lockdown, the fire-break lockdown that we have, which did certainly show us some benefit, but that feels like it's dissipating already. And of course, our hospitals are also busy, as has already been mentioned indeed by the chair in our opening comments. We've got at least as many, if not slightly more, patients in our hospitals now with COVID than we did in the spring peak. It's relatively stable at the moment, but that could change. We're at the sort of 100 to 110 level across all sites, and including the community hospitals. But on top of that, we have around 50% more non-COVID patients in our beds than we did back in the spring. And of course, we're dealing with a number of outbreaks ourselves in hospitals. I think all of this demonstrates, whether it's the community transmission, Cardigan, the outbreaks in hospitals, just how difficult it is to contain this virus. It doesn't take a day off, even though we might want to take a day off from complying with the rules and the guidance. And I guess, as I've already referred to in the previous discussion, the sense of strain and exhaustion across the health board for all of our staff, is palpable, I think, at the moment. And I think it is important that we do everything we can to support our staff over what is going to be coming over the next few months. It's very easy to say it's going to be one of our most challenging times, but that's exactly what it is going to be. I guess more positively, the work of our TTP, particularly our contact tracing team, both at the local authority level and at the regional level, that is working very well. We still have rates in the sort of 80s and 90s for being able to contact people. And I would like to thank our local authority colleagues for everything they're doing in that sphere to manage these clusters as they appear. And also in our hospital settings, the outbreak management teams that have coalesced around each of those, their work has been fantastic, and quite often 7 days a week in managing that. And I think we are demonstrating that we are able to contain those as they happen. The public support, as the chair mentioned at the beginning as well, is also really great to see. Most members of the public are complying. There's a high rate of compliance. However, we do see, particularly at the end of the firebreak period, and this linked to the issues in Cardigan, that there can be a letting down of a guard, a sense that the end might be in sight. And of course, with the news around the vaccine, that is positive. But I would just reiterate for the public who might be listening to this in particular, this is not the time to let our guard down. It's still very early days. We don't have a vaccine yet, although we are very hopeful it will come soon. But even when we do, it's going to take us many months to get to the levels of vaccination that will make a difference to this. So, it's absolutely not over yet. And overall, we've attached here the Q3, Q4 plan, despite all of the pressures we're feeling, and with some exceptions at a very local level. We believe we're on course to be able to deliver that Q3, Q4 plan as we currently stand. And that plan essentially tries to maximise across all of our services the things that we can do in the context of this pandemic, the staffing that we have and the facilities, both in our essential services and in planned care services. So a real sense that we are straining everything to keep all of that running at quite a difficult time. Individual execs, as I've mentioned, might want to update on their latest position if that's required by independent members. Although I would just recognise for the public here, we do have regular discussions with IMs, the chair and I, and being able to update in this sort of fluid environment that we're in. And can I just apologise that there's an additional recommendation that didn't make it into the paper, though it is sort of referenced in the body of the text, which is alongside ratification for the gold decisions that we've been making, is to ratify the Q3, Q4 plan. I think it is a good plan. And just to note that there has been a change to the gold command requirements, even since they were written a few weeks ago, around the intensive care numbers, which we're seeking to sign up today.
Thank you, Steve. I'm going to bring in some of the questions and then we check whether we need any more updates. Can we have, with the current clusters in Ceredigion, how confident are we that the mitigation that we have put in place will ensure it doesn't impact on staff?
Lisa Goslin's going to answer that, Chair.
Okay, Lisa.
She was going to type in the chat bar, but she's there.
There we go.
Hi. We aren't confident in terms of the impact on our workforce, because obviously these things do have an impact. What I am confident about, however, is that we have got a very agile workforce plan. We have been recruiting new individuals to support us in our future work programmes. So what we have been doing is deploying individuals in to cover the gaps that are identified as part of any need for self-isolation or for staff who need to take time off due to childcare arrangements. We have got All Wales agreements in terms of how we support our staff who need to take time off to do that. So it is something that we are managing on a day-to-day basis. We have got additional workforce that we are using to support staff, and we are bringing new recruits in every day.
Thanks, Lisa. And Alison would like to come in on that point as well.
Yes, thank you, Chair. It's just to sort of give some additional assurance that actually the TTP process is working extremely well. We're flexing very quickly. So within a matter of less than 24 hours, we moved one of our MTUs from Aberystwyth down to Cardigan to deal with the outbreak there. And we are making sure that any staff that are affected with any symptoms, that we are getting them tested very quickly through whichever route is the quickest at the time. So we've been very flexible with that. And I have to say that the teams have been very, very responsive in mass testing the staff where we've got outbreaks on wards. So just to provide a bit of assurance around that we couldn't go any faster, I don't think, if we wanted to.
Alison, that's really, really reassuring, and thanks, Lisa. I have a question from Maynard in terms of flu vaccinations. And Delica's asking the same question. How does the uptake shown on page 6 of the report compare with previous years?
Shall I answer that, Chair? We've had a fantastic response this year. In fact, actually incredible across all of our risk groups, especially our staff, if I'm going to be honest. Still have to remind ourselves we're only 8 weeks into the flu campaign, and from a staff perspective, we've already vaccinated well in excess of what we vaccinated in the whole campaign last year. So we're up nearly at 6,200 members of staff. So absolutely incredible. So a very positive step forward compared to last year. And we can't forget actually the lion's share of the work in terms of the flu campaign takes place across our primary care services, and they've just been doing an amazing job this year, considering the challenges around social distancing with regards to the way that they have to organise their clinics. It really is quite a feat they've achieved this year. We've had some amazing performance across practices within all of our areas, but especially I'd like to commend across Carmarthenshire, who have really managed to lead the way with regards to how many they've vaccinated across all of those key 3 risk groups that we can see there. The over 65s, the under 65s at risk, and our 2 to 3-year-olds. So we are seeing a real improvement in terms of the uptake figures achieved last year. Can I just also add, Chair, in terms of the previous point, I'd like to say that the contact tracing teams are doing a sterling job in terms of follow-up for all positive cases, but then their continued follow-up with regards to all contacts. And they are taking a very clear line, but a very sensible line, that they're only asking people to self-isolate when they really are at risk of exposure. So again, we are taking the necessary precautions, but not taking so many precautions that we're actually making people stay off and have to self-isolate when there really isn't a risk of exposure. We're taking great care in trying to gather as much information and intelligence as we can during those lengthy contact tracing interviews.
That's wonderful, Ros. There's a question about the field hospitals update, and I think Andrew come in to answer that.
Yes, and in doing so, Chair, I'll just give a very quick update on the modelling position as well as I answer the question, because it will inform the answer. I think just before I do that, though, I do want to extend my thanks and gratitude to all of our staff working out there on the front line at the moment in what are very difficult circumstances. I don't think we should underestimate the strain, anxiety and pressure that they're feeling at the moment, as we certainly are having our most difficult period of the pandemic so far. And it's certainly had a significant impact on our staff availability to this wave of the pandemic, more so than we've seen previously. And I know the lengths that our teams are going to maintain services and keep services going. And I'm also grateful to the support of some of my colleagues and their teams for the way they're helping to redeploy people into those services to provide additional capacity, and also to Lisa and her workforce team for the tremendous work they're doing trying to recruit at levels that we would normally sort of bulk at, I think, in terms of deliverability. So that's really important. I think it's important we recognise that. In terms of, so just in terms of where we are, I think Steve outlined where we are in terms of our current levels of activity. In terms of the modelling, we're probably more or less where we thought we would be when we were looking at the Swansea model in doing the Q3 and preparing the Q3 and Q4 plan. There are signs in the last week that there is a positive impact from the fire break a couple of weeks ago, and we're possibly starting to see a stabilisation and plateauing of the number of positive cases in our hospitals. It's too early to say if that will be maintained and reduced, because we believe our transmission rate, so that's the R figure that gets talked about, to be just above 1 at the moment. So whilst it remains above 1, we can reasonably expect to see an increase in patients coming through to hospital admission, but we expect at the moment that rate to be slower than perhaps over the next coming 3 or 4 weeks than perhaps we'd originally modelled. So I would expect to see, in terms of our forecast position, a deviation from that in a positive way in terms of our numbers reducing. But obviously, as we've talked about many times, it's very fluid, very dynamic, and things can change very quickly with this virus. But I think we've got a confidence in terms of where we are with our plan that we've got in place. That's not to say there aren't constraints and risks that we're having to manage, and the staffing constraint or risk of the staff of the absence has been a real difficult challenge. And I think the last 2 weeks and probably the next 2 or 3 weeks are probably going to be some of the most challenging we've had, and more so than we would normally see in any given winter. With that in mind, we're obviously implementing our various escalation plans and site plans to respond to the differing needs and demands that are being placed on the service. It has this week, or in the last couple of weeks, had a bit of a minor impact on our surgical planned care restart programme that we've outlined in the Q3 and Q4 plan. So last week there was an impact on some of our on a very small number of cancer patients on our ENT cancer pathway. We've managed to re-establish that this week and get all those patients back in for their treatment this week. So that was a very short-term blip. We've also, in terms of the pathway and access to those beds, we've got a delay as well, pause at the moment on our restart of orthopaedic urgent work in Prince Philip. It has recommenced in Bwrdd and Willibush, but because of the ongoing demand and pressures, both staffing and COVID numbers in Prince Philip, we've had to pause the restart that was intended there, and we are reviewing that on a daily basis now to understand when we might be in a position to launch that in Prince Philip again. I think as part of our plan, therefore, and because of the demand we've seen, it's not just, I think we should remember, it's not just hospitals that have been affected and hospital staff, NHS staff that are affected. Our social care partners and are also seeing that impact, and that's definitely had an impact on our ability to discharge patients in a timely way from hospital, which has added to the overall system pressure and bed occupancy position. To help mitigate that, we last week opened Ysbyty Enfys Samhain Samuel in Llanelli, our field hospital there, to provide additional capacity, and as of yesterday we had 14 patients in that field hospital. We are looking at extending that to 18 patients from today to help take a bit further pressure off Glangwili and Prince Philip, with an intent to, we'd always planned to increase to 28 beds in there by the 7th of December, but we're looking to accelerate that increase in capacity as we go into the weekend to support the current site pressures. We're also seeing a building pressure largely because of non-COVID demand and the discharge pathway element in Pembrokeshire. So we will be looking to open next week and are mobilising our plans at the moment in terms of staffing to open the field hospital at Bluestone from probably late next week. It's looking like at the moment, by the time we've got the staff there and inducted them into the site. With the growing position in incidents in Ceredigion, we've also started, in our experience of what's happened in Carmarthenshire and and other parts of Wales, when you start to see the incidence rate go above 100 cases per 100,000 of the population, we've also started our initial mobilisation of getting Plas Krug ready in case there's a need in 4 to 5 weeks' time for us to look at additional capacity to support Ceredigion should the current incidence rate be sustained and that start to translate into increased hospital admissions. So that's really the latest position in terms of our modelling and our field hospital position. I'm happy to take any other questions if there are any.
Thanks, Andrew. There's an awful lot of messages in the message bar about it's incredible how everyone is pulling together, and it's wonderful, you know, what everyone is doing is such a positive reflection on the values and culture and the leadership, and it's really important that we hear it from the execs firsthand, because it is absolutely a massive achievement and a continuing challenge. Does anyone have any more questions of Andrew? Okay, thank you. I'm going to bring in Mandy now, so Mandy can talk to us about the hospital outbreaks, PPE and social distancing.
Thank you, Chair. I will keep this brief, and it's really partly to provide reassurance to the public and our patients about the position that we find ourselves in, because hearing about hospital outbreaks and ward closures, hospital closures, really does cause people to be quite fearful, both our patients, public, and also our staff as well. But what I can say is that the way in which we manage a hospital outbreak is extremely rigorous, and as a consequence of the arrangements that we have in place with the outbreak control team arrangements, which are called every time 2 or more patients in a particular clinical area are found to be positive for COVID, or indeed if we are identifying any staff member who is testing positive for COVID. Those meetings are chaired by the relevant site head of nursing, and they are absolutely supported by the general management team, by the hospital directors, the ward staff concerned, public health, our TTP colleagues, our CCDC, so our communicable diseases consultant. and the full range. Plus, as well, Andrew and I personally attend the outbreak meetings as well to ensure that we can provide support and oversight. And at every time, the infection prevention control team are absolutely sitting alongside the site team to provide the necessary support. In taking that forward, what I would say is that as well as managing the outbreaks, we are able and have successfully closed a number of outbreaks across our services. And again, that is down to the diligence and hard work of everybody pulling together. So I really want to take this opportunity to reassure people it is safe to come into hospital when you need to come into hospital. And we have these arrangements in place to protect the public, to protect our patients and to protect our staff. So I just wanted to flag that. The other thing I just wanted to mention is that I'm part of the National Nosocomial Transmission Group, and we're working very hard to make sure that the guidance is updated and reflected to be able to help us to manage patient care safely, but also to support continued attendance at hospital, patient flow, and to make sure that people can be discharged to the most appropriate setting in a timely way. Thank you very much.
Well, that's really reassuring, and it's really important that the public who may be watching this live stream hear it directly from the experts. So many thanks. I'm going to bring Ros in as well to give an update on the mass vaccination programme and any other issues she wishes to give us an update on.
Okay, thank you, Chair. So yes, we're all very, very busy at the moment. Isn't it great news, first of all, that we've got vaccines on the horizon? And I know we've got to wait for the regulators to approve, ready for use, but it's just so heartening just to see just how much work has been done, and we've got these coming over the horizon. So that was my positive start to this update. So we're very, very busy planning for our mass vaccination programme. We're focusing first on the Pfizer vaccine, which has been closely monitored at the moment. And although it's a very rapidly moving feast with news coming through literally every day with regards to developments and new information, we're planning on the basis of 5 scenarios at the moment, and that depends on the delivery characteristics of the vaccine, the volume, the unit size that we receive in, the number of sites that can be delivered to, and a whole host of others. So it's not a simple process, but again, the planning team are working very, very hard just to make sure that we really do understand and we can respond accordingly. As soon as that vaccine is made available, we are going to be able to start and vaccinate our priority groups as set out accordingly. So busy space, but a very positive space, if I might add, because it's just so heartening that we've got something like this to be working on.
Thank you very much, Ros. Do any members have any questions for our executive leads or our chief executive? Okay.
Can I just
please.
I'm just very proud of what this team is doing right now. They're all doing just amazing jobs.
Totally agree. It's really, really humbling to listen to the extent and the expertise and the dedication at this particular moment in time. And a massive thank you from the board on behalf of the population for everything you're all doing. And I'm going to now go to the recommendations to ratify the Goa Command Group planning requirements as amended, and also to approve the Q3, Q4 plan, which has gone to the government. Yeah, everybody happy to do that? Thank you. So the next item on the agenda is the annual presentation of the nurse staffing levels awards, and that's Mandy.
Thank you, Chair. I won't take you through the detail of what is an extensive and very detailed report and attachments. And I suppose I just want to reflect upon the fact that obviously it is a requirement for me to bring this report to board, which is why it's here before you today. What I will focus on is the fact that this has been an extremely challenging environment within which to undertake the review of the nurse staffing calculations, which we are required to do under the nurse staffing Levels Act. Partly because no sooner than we've undertaken the calculation than for operational reasons, the wards have changed. We've had to make amendments, whether they become a COVID green area, as we're calling them, or a COVID positive management area, looking at splitting the streaming around our front doors in particular. So all of that has made this a very challenging time in which to be doing it. And what you will see within the report is that there is definitely an impact, both in terms of staffing, as we've heard about, from COVID, but also in terms of the non-COVID areas that we've presented within this report. So there are some things that we committed to undertake, which was particularly around ward staffing, ward leadership. That, despite COVID, has continued. So the leadership programme, the STAR programme that we put in for our sisters charge nurses, despite COVID, we found alternative ways of continuing to deliver that, because leadership is essential now more than ever. So that has continued. We've seen some pathway changes, particularly around NIV, non-invasive ventilation, CPAP, and also thrombolysis, and that again has had an impact upon the staffing levels. And from there, we're going to be having to do a further piece of work to actually undertake some benchmarking internally about the staffing arrangements to support those different and new ways of working. So I'm not going to say anything more than that, other than the fact that, as I mentioned in the patient experience report, we're also looking at different ways in which we can support and wrap a team around the patient. And some of that may include the introduction of ward administrator roles, etc. But we're still working through the detail of that at the moment. But I'm happy to take any questions.
Thank you, Mandy. Open to questions, members? Okay, thank you. Yeah, thank you. I think everybody is obviously very happy with the report. There are no questions. So everybody happy to accept the recommendation. Many thanks. We're now going to go on to the performance report and over to Hugh.
Chair, diolch yn fawr. I'd just like to take you through some of the headlines from the performance report for the month. If I just pick out some of the key issues which are highlighted on page 2 of the SBAR. So the position on unscheduled care is, again, we've noted the declining trend. The position stabilised in October across, stabilised or improved across the 4 metrics that we're tracking, but further challenges have been experienced in November, and I'm sure we'll come back to that. In planned care, RTT breaches have again increased, as we would expect, given what's happening, given what Andrew's already said. Work is underway on risk stratification of our patients who are waiting through the patient administration system, so we can report on this in a different way in the future, and that's work that's going on across Wales. That said, we've made improvements in diagnostics and therapies waiting times, and I know that the Attend Anywhere has been a contributor to support some of those improvements that we've seen. The stroke target of admissions to the stroke unit within 4 hours hasn't been met again, but we have met the target of patients being seen within 24 hours by a stroke consultant. And cancer as well, we didn't meet the target for urgent suspected cancer, but we did meet the non-urgent suspected cancer target. Worth noting the improvements in healthcare acquired infection rates, although we do remain bit below target, but there is a significant improvement year on year. I also want to pick up mental health, which hasn't been picked up in the SBAR, but is in the body of the report, and the challenges which are within mental health in achieving the pathway targets, both for children and adult services. With that, Chair, I'll open up to questions.
Thank you, Hugh. Can I ask, have questions, please? I'd like to ask a question. Have we appointed a stroke lead yet?
I ask Andrew.
Yes, Chair, we have. Dr. Senthil Kumar from PPH has been appointed as the new Health Board Clinical Lead for Stroke, which is great news.
Thank you so much. And could Judith and John.
Yes, thank you. Thank you, Hugh. I would like to just ask a question. Bear with me because my system went down on the iPad. In terms of the main body of the report, it's on page 14 in relation to mental health. I suppose a couple of things. I mean, first of all, I am concerned about the way we present the information, and I don't know if that is to do with Welsh Government requirements, but I think, you know, we say nearly 18% of children waited less than 26 weeks. Well, that means nearly 85% of children waited longer, and they're not particularly mentioned in the planned care lists, and then the same about adults. Now, I do know that there's a lot of work going on, and this, whatever I say, is no way a criticism of what is a very small team trying to address this. But when I look about the actions, and all of those are entirely appropriate, but I, you know, do have real concerns about the impact this is having on children and families by this continuing length of waits for assessment. As I say, I'm aware of a lot of the work that's going on between mental health and child health, but it does continue to grow, this list, and we are therefore, I feel, sort of building up issues for the future if we don't provide this service to these families and children at an earlier stage. So maybe it's something that I know that the Quality Committee is going to be looking at, but I did want to register that, and there may well be some immediate response, but I am happy to take a fuller discussion outside the meeting, which I have been involved in.
Chair, I'm happy to come in on the first point around the way in which we're presenting the information, and I agree with you on reading that it reads in the positive when the issues are clear given the numbers that we're seeing. So we'll reflect that in future reports. Andrew, do you want to comment on the performance position?
Yes, please, and thank you, Judith. I know this is a continuing area of concern that you've raised with me individually and through the board discussions, and it's, you know, I think I would agree and want to extend my apologies to all the families and children and adults out there that are waiting to access these services and the delays that they're currently facing with some of the challenges we've got. As you said, there's a detailed conversation going to take place and a deep dive into these services at Quality, Safety and Experience Committee next week on the 1st of December, so we will be able to get into the detailed scrutiny of this. But if I may just add just a couple of points just to respond. I think firstly, you're right that, as Hugh's outlined, the way that that's framed could be interpreted as we're trying to put a positive spin on where we are. The target is 80%, and by any definition those two measures of 17.7% and 26.2% are nowhere near 80%, and are definitely obviously and clearly areas we need to work on and improve our service delivery and timely access on. The Directorate have recognised this, and they've just a couple of things. They are in the process of restructuring the management structure slightly, so now ASD services will be managed by one service delivery manager or head of service. They won't be split across adult and children and young people at the moment, and we believe that'll help the overall management of the service and bringing together our delivery plan. We've also within that arrangement managed to bring in somebody who's actually, as well as experienced in mental health and learning disability services, is also experienced in waiting list management and demand and capacity work, which we felt was an important skill given the challenge we face. So we're hoping that those two things will help give an added level of management focus and scrutiny and skill to managing the position. I think the impact of COVID over the last few months has definitely affected our ability to improve our performance and service in the way that we wanted to. We have had, we know we've had money allocated from Welsh Government for diagnosis and assessment, and our ability to recruit has been impacted by COVID and delays that's put into the system in terms of people wanting to come and do those roles. We've also seen an increased level of anxiety about engagement in face-to-face assessment. We know that with these services, face-to-face assessment and intervention is the best way to manage and deal with the issues that it presents, but there's been increased anxiety from both patients and carers and families and some of our clinical teams around those face-to-face assessments, given the current social distancing guidelines and the current the virus. We are using new technology like Attend Anywhere to increase our ability to provide capacity, and we're also looking at how we can find further spaces that would enable us to provide more genuine face-to-face, physically face-to-face assessments in social distance compliant facilities. So I'll put my get my words out there. So on top of that, we are seeing an increasing number of referrals for the service and impact, and that's a pattern that is being seen across Wales, and there's an increased acuity that we're seeing across Wales. And so I know as a service, the team are very concerned about that and looking at how we respond to that going forward. I suppose what I would just want to say, we are in a, we know we're in a difficult position. We know the waiting list is at a level that is too high and is certainly not where we want it to be. We did have a position like this 4 or 5 years ago as a health board where we had similar issues and we saw similar growth, and the team did demonstrate an ability at that time to address the position over the course of a year, 18 months from a similar place. So I'm optimistic that when we manage to get everything in place that we need to address the current challenges, we will be able to make progress on this. But as I say, we can go into the much more detail around the impacts and issues at Quality and Safety Committee next week.
Okay, thank you. I think it's just making sure this has the parity with all the other planned care areas and the resources to support the teams in coming to solutions. So thank you for that.
There's a number of comments and questions in the message bar. One is from Delith about what support or information is given to the children and young people and families as they are waiting. Another from Paul is that the waiting list is for assessment. So part of the issue is once assessment has taken place, what's the plan to improve access to services? And obviously people are saying, Anna is saying it's essential we give mental health parity of esteem with our physical health services during and beyond the pandemic. So I wonder if you could pick up either now the two issues about both the interventions as well as the assessment, and also the support or information during the waiting time, either now or in the detailed session at Quality, Safety and Experience.
We can certainly pick up the detail next week, Chair. I think that one of we do. I mean, I recognise the issues that are being cited there by independent member colleagues, and we have had some issues in terms of the services where patients go following assessment. We commission those, and we have had some issues with some of those providers no longer being able to provide the services that we need for our population. So we're obviously looking at that and working through our plans to resolve that and find alternatives. So, but we can go, as I say, we can go much more into the detail next week.
Okay, many thanks. There's one of the risks within the paper under mental health at page 14 talks about the lack of a robust IT infrastructure, and we've made incredible strides in IT during the pandemic. And I was fortunate to meet with two of the members of the team last week, who talked about how the Attend Anywhere is working really, really well. And some patients will much prefer to do it virtually than to travel, or if they have concerns actually leaving their own home, it's much more convenient. I just wondered, and this might be a question for Hugh, what plans have we got to improve the IT infrastructure?
Yeah, Chair, the risk is probably diminishing now, and if I just reflect on the work that's been done over the last few months, not only in the rollout of new technology, but the core infrastructure through the patient administration system now has fundamentally changed in mental health. So all inpatients, outpatients and community contacts have now been migrated over to Welsh PAS. There are still some data quality issues as a result of that transfer, but we're now looking at a date when we can decommission the old infrastructure, making sure that all that data has been transferred, exported and safely stored. So the risk is diminishing, certainly in terms of that infrastructure.
Many thanks. And I'll bring in John and Michael shortly, but I just want to say there's a message in the bar from Anna that she'll make sure there's a thorough discussion at Quality, Safety and Experience Committee next week and report back to the next board. So many thanks. John, you'd like to ask a question?
Thank you, Chair. Can I just ask, with regards to one of the performance targets, which is delayed follow-up appointments, I'm sure for all the board it's uncomfortable to read some of these statistics that we're seeing in terms of the referral to treatment waiting times, but I was surprised to read that particular one, bearing in mind that most of the follow-up appointments are now being done virtually. So I can't understand how it's going up. Or am I misinterpreting that particular target? So it's delayed follow-up appointments. It's escalating from 34 up to 40,000. I would have thought the trajectory would have been the converse.
If I may, Chair, I think a significant part of that increase has been caused earlier on in the pandemic, when we suspended all planned care activity for the initial period of the first wave, and that took down all of our capacity. We now have 10 services that are utilising telephone follow-ups as well as the digital solutions to increase the capacity we've got to see patients. And my understanding is that since the first quarter, the capacity and activity we've been undertaking in follow-ups has increased. I'm happy to provide find a more detailed update and maybe bring that to the Performance Planning and People Committee, if that would be suitable. John?
Thank you, Chair. I think we should be encouraging that, because that is one way in which we can positively impact on patient experience by following up via telephone or virtual consultations.
Thank you. I'm also going to bring in Phil and Hugh. I think it's on the same issue.
Yeah, thank you, Chair, and apologies for the lack of corporate background. The computer is saying no on that at the moment. So in terms of Professor Gammon's question, I suppose there'd be a couple of points. One is Andrew's point that some of the backlog was created right at the start of the pandemic, when we were asking our clinicians to do there was an enormous amount of effort that had to go into COVID retraining. So yeah, they were reprioritised onto those acute activities to safeguard the most vulnerable acute patients. Remembering even now, they are still, and we've just heard in the COVID update that it's almost even more challenging now, because we're asking them to undertake the acute care in a very difficult circumstances, with increasing COVID activity, with rates in our hospitals at the same level as they were at their peak in the spring, and asking them to undertake as much planned care activity as possible. And the other perhaps misconception would be that a virtual clinic takes less time than a face-to-face clinic, because actually that often isn't the case. Telephone and attend anywhere video clinics can sometimes take longer, because you are missing a lot of the cues that you would be used to having in a face-to-face situation, and that's both for the patient to try and get across to the clinical member of staff. They sometimes need more time, and plus for the clinician to try and decipher the data and information that is being relayed to them. It takes sometimes longer. So the thought that it makes it quicker. I mean, it's brilliant that the patients don't have to travel. It's great for parking. It's great for the environment. And I expect clinicians will get better. It's also a way of working that is new, and we're learning and getting used to, and the evidence base, I suppose, is developing on this. So the fact that there's a waiting list in the way described is, I suppose, not surprising. But on the other side, it's something that's a really huge challenge that is at the moment affecting our public's access to appointments, that you know, and it's affecting all of their lives, and have to recognise just how stressful that is. My hope would be, you know, it's really pushing the boundaries of innovation and creativity, and as we find our way out of this, as the COVID haze will inevitably dissipate into next year, we have to find a way through this, both for virtual appointments and for interventions and procedures that people are also waiting for. And we'll do that with the being as creative as we possibly can be, and also with our public's views and support from our CHC, with all of that in mind.
Thank you. I'm going to bring in Michael, please. If you could, thanks, Michael. You can turn your camera on.
Thank you, Chair. So my question really is more about the overall picture. I think it's worth recognising, as we all do, we're not living really we're living in exceptional times at the moment, but we won't always be in exceptional times. So my question really is, are we doing any work to understand how much of the picture that we're seeing at the moment is driven by the exceptional nature of responding to the pandemic, and how much isn't? And have we got a sense of what we'd like the picture to look like in 18 months' time, and how do we need to prepare to come through stronger to achieve that picture? I'm quite happy to take that sort of offline if that would help, but I just need to understand, I think, that we're not just kind of just looking at the performance as it is, but that we're actually looking at how we want it to be in about 18 months' time, and are all the interventions that we're pursuing at the moment likely to handle and land the numbers where we want them to be?
Thanks, Michael.
I might attempt to come in on that very, very large question, Michael. I think there are a couple of elements to that. I think there are clearly the things in our performance that you could absolutely say that is the impact of COVID, you know, the really obvious barn door things. I think part of the problem with what you've described as kind of can we assess where we're going to be in 18 months is a lot of the ways in which we're handling that and the things we're doing are very new, and they're evolving as we speak. So that includes virtual clinics, but also everything we're doing has been thrown in the air around this, about how you operate theatres, how you bring people into hospitals, and so on. So I think probably the short answer is no. I mean, we know what we want to get, which is we want to deliver all the targets that are set for us by Welsh Government and others. That has to be our ambition. But we're still in the middle of this massive evolution of the way in which we deliver everything. So I think there are probably a number of positive things behind some of this data, which we're yet to see the full benefit of, whilst we see the really obvious issues and challenges that are coming out of this, particularly around planned care services. It's yet again a worthy challenge that I think we'll need to get our heads around over the next few months, so that we can get a sense of what our trajectories will be going forward. We did, as you know, had an interesting discussion from Lightfoot yesterday around the use of data to help drive some of this, and in that sort of tactical space that we talked about yesterday around planned care. First of all, being able to understand and forecast what will happen if nothing changes, and then being able to find how we can tweak the system using that data to be able to make those trajectories get back to where we need them to get. I think that's going to be a key part of work going into the new year for us, but I'm really hoping that Lightfoot capability, as well as that the operational benefits that will give us that tactical benefit of addressing some of the problems that sit behind this.
Thanks, Steve. I think part of my question was an encouragement to make sure we find the bandwidth to do that thinking, rather than just keep getting into a monthly cycle of doing the job, producing the numbers, and really not having a longer term view of are we turning the handle in the right way to get the right outcome.
Yeah, and I think probably my reflection would be the bandwidth is one of the biggest challenges at the moment.
Thank you. Hugh, I think you want to come in.
Yes, thank you, Chair. And it partly relates to Michael's question as well, but goes back to the question earlier on about the impact on follow-up backlog. And we have seen where areas are embracing, where directorates are embracing the use of technology, that there is an impact on the position. And I know therapies have really embraced the use of Attend Anywhere, and that has certainly helped them achieve or kept on top to a certain extent of their waiting times. And we're seeing a growth in use in other specialties, which will have an impact, no doubt, on follow-up backlog in rheumatology, respiratory in particular. And it's certainly something that is going down well with patients as an easy way of interacting with the service. I think linking back to your question then Michael, I think there is something for us to consider about digital disruption and value-based disruption into the way in which we're looking at our pathways, the way in which we're delivering care, which will have a huge impact on our performance in the future. We need to understand what that looks like in a more normal space, and I think some of the support that Lightfoot can give us and informatics are opportunities that are developing now will help us model that more effectively into the future. But we're nowhere close to that, understanding that yet. There's much more work to do.
Okay, thanks, you really helpful.
Thank you. Thanks everybody. The recommendation is asking us to discuss the report in the light of the COVID pandemic, and also arise any issues arising with the content or format changes. I'd just like to say the report has really improved in its format, the clarity, and the way it's set out, and also the detail. So I really thank you for that, Hugh. I know it's a new portfolio for you and your team. But picking up on Michael's point, when we get to that stage where we've got our projections, we've got our trajectories, and we can look back and look forwards, that's when we'll be getting to a place where we'll understand, are we where we should be, and if not, what we're doing about it, etc. But this is a big step in the right direction, so thank you.
Thank you, Chair.
I'm going to give everybody a comfort break for 10 minutes, so we'll resume then. It's 11:12, so we'll resume at 11:22, if my maths is right.
Yes, your maths is correct.
Okay, and thank you everybody. Welcome back, everybody. Can everybody hear us? Okay, thank you. The next item on the agenda is the corporate risk register. That's over to you, Steve.
Yeah, thank you. So I'm going to ask the board secretary to pick up some of the specific issues in here, but just a couple of things from me. First is to thank the board secretary for her and her team's ongoing diligence in keeping our corporate risk register updated and aligned, and working with the execs leading in this. The board members will also see in the report that the work around the Q3, Q4 risks we're suggesting taking through committee. I think that's simply a reflection of the fact that the speed of development of that plan has meant that whilst the risks themselves are being actively identified and managed by both the tactical and bronze teams, actually getting them captured and written down has probably been a bit slower than we would have liked. In fact, you should probably, as our board secretary often reminds us, identify the risks as you're starting off the project, because it helps you think things through. So there is a bit more work to do, I think, on that, but I think it's simply the speed and, going back to the phrase used earlier, the bandwidth that people have to be able to do all of these things. So that work is underway now. We've had a meeting where we've run through all of that with the execs, and we will take all of those risks through the appropriate committee. So I ask for, again, some board forbearance on the fact that we didn't quite get that the right way around. And I was going to ask the board secretary if there's any specific things that need to be clarified.
So I was just going to add, really, so that just to update on the paper, so we did hold the risk workshop, and all the risks that are on the corporate risk register have been gone through and reviewed by the lead executives there, and you'll notice that there's been quite a bit of movement since the last time this was presented to the board and through the committees. So just to flag, really, the areas, there's 7 areas where individual execs are working through to include on the corporate risk. Those will be in relation to unscheduled care, delivery of cancer services, mental health delays, and planned care, which the Director of Operations is working through. There's 2 for the Director of Primary Care in terms of primary care and community care risks, and there's also a risk relating to the reputational risk regarding the mass vaccination programmes, which the Director of Public Health is working through. So I'm not going to go through the risks. If there are any questions, those would be to the individual execs who have ensured that those risks are on the corporate register. But there is just one area to flag to the board's attention, and that was following a discussion at the Quality and Safety and Experience Assurance Committee in relation to a risk on urgent primary care. So the board is asked, following that discussion at Quality and Safety, to agree and accept that risk, and that it could only be reduced at that time to the target risk score of 12, which actually means it will be above the board's agreed tolerance. So there was a real great detailed debate, and it was felt there was actually no further work that we could do at this point to reduce it to the board's tolerance level. So the committee was asking the board to accept it at that level, and we will obviously ongoingly review it, but recognising at this point in time we will not get it to our agreed level of 6.
Thank you, Jo. Are there any questions from members? Anna?
Thanks, Chair. Yeah, I just wanted to seek some clarity on page 6 of the S-bar. Risk 6 to 8 is the fragility to therapy provisions. I noticed that the risk has been downgraded, but the narrative that fits with it, and also in the more detailed risk register, refers to demand not aligning with capacity, the current flexible arrangements not being sustainable. So just seeking clarity as to why, given that narrative, the risk has been reduced.
Should I answer that, Chair? Yeah, thanks, Anna. Yeah, I suspect maybe we should take a little bit more care with updating the narrative, because I think the narrative that you're referring to has probably been the narrative that's been there for a while. Lance and I actually had a very detailed conversation about this a couple of weeks ago after the Queesiac meeting. And although we do still have gaps, absolutely, in therapy services, I think we recognise that over the last 18 months in particular, we've made some significant headway with some areas. So if I call a few out, we've had significant national dementia funding, which has put posts in for dementia. We've had the funding from the business case for inpatient malnutrition. So some of the big areas that were really worrying us have actually been resolved. Now, there are still areas that, are not up to full capacity, but after a very long detailed discussion, we did feel that we're in a much better place, and it would be right to actually downgrade that risk. It's still there. We'll be keeping a very close eye on it, but it actually felt wrong to keep. It's had the same risk score for quite some time, and that didn't really reflect the improvements that have been made. So I take on board your point, though. It does still start off, having reread it, as we've got significant problems. I guess we've got less significant problems than we did have. So we'll maybe look to revise that wording before it comes back to board next time. But right for you to pick that up, because I appreciate you had a discussion at Queesiac on it.
Yes, we did indeed. And Alison, the detail in Appendix 1 also suggests that we're not in the state that you've just described.
Yeah.
So I think it needs a look at to make sure that there's a consistency between the risk score and the
and the messaging. Absolutely.
Thanks very much.
Dana, thanks for raising that, and thanks for the response. Any other questions? Okay, the board's happy to accept the recommendations. Thank you. Thanks, Jem, and thanks, Steve. Next item on the agenda is the report of the People Planning and Performance Assurance Committee. John?
Thank you, Chair. This is the report of our meeting held on the 29th of October. This is a summary of what was discussed and where we gained assurance from the matters that were on the agenda and the issues there in terms of what we're seeking approval for, as well as some of the areas of concern. I've got nothing to add to that report unless there are any questions that colleagues would wish me to answer.
Thank you, John. Are there any questions from colleagues? Judith and then Maynard.
Sorry, no question from me.
Okay, sorry, it came up on the message bar, but no problem. Maynard, is the one from you?
Yes, Chair. It's just really to add a comment to the update on Women and Children's Development Phase 2, that the report at PPAC did note that there were benefits being realised at Glangweely, particularly in Skaboo, from the work that's already been done. And I think that those improvements are worth noting.
Thank you. Thank you, John. And we have approved today, following your scrutiny at the committee, the business case to go to Welsh Government. So many thanks. Next item on the agenda is the report of the Quality, Safety and Experience Assurance Committee. And Anna.
Thank you, Chair. Yes, and board will notice that we have two reports this time, which reflects the fact that we have stood up our Queesiac assurance arrangements as per the earlier agenda report under good governance item. The reports stand, but I would like to draw the board's attention to the November report. We met on the 13th of November. We recognise the position at the Penally site is dynamic and things are likely to have moved on since then. But just to report the position at the 13th of November when the committee met, we discussed that item in detail. We were assured in terms of the excellent partnership working that has been happening amongst a number of local stakeholders, including, of course, our own teams and services, trying to ensure that the situation in Penally can be managed as best as possible. But the committee was unable to seek or to find the assurance that it was looking for in terms of the fitness for purpose of that site, and taking into account the Health Board's inquiries and the fact that at that point in the month there had not been a response from our latest request to the Home Office, we did make a decision as a committee that we should refer the matter to the board. So drawing attention to that, please, Chair.
I understand the letter that Steve and I sent to the Home Office raising our concerns and seeking assurance that our recommendations to make the site as secure as possible in relation to COVID had been followed. I wonder if we could have an update on the matter since we sent that letter.
Yeah, thank you, Chair. So yeah, we have had a response to that letter now since Quality and Safety Committee met, and thank you, Anna, for taking the paper and the concerns into consideration at that committee. We have also done a further response back in relation to that letter, which went off either yesterday or the day before. I've asked Mandy to bring it to the Quality and Safety Committee as matters arising, both copies of the letter. I think what I would summarise at board today is that we haven't received the level of assurance or information to back that up that what we were hoping for from the initial letter, and really that was the purpose of my follow-up to them, to make that clear and to try and draw a line under the issue and ensure that the Home Office were clear about their responsibilities. That's kind of where we stand today. So the teams, as you say, continue to deliver all of the services that we need to deliver for that population, the residents on site. But the fundamental suitability of the site, I think, remains, we remain unassured of that despite the correspondence.
Thank you. I wonder if I can see Jill. Jill, did you want to come in on this?
Yes, thank you, Chair. I just wanted to commend the teams really for the work that they have done in terms of providing GMS services for residents on that site. I think we continue to have challenges, however, and the board will know that following some unrest on the site in early November, we had to move the services that we were providing on a face-to-face basis for residents to South Pembrokeshire Hospital. So what we currently provide is a daily remote service for access to triage anyone requiring acute services, and then we have a twice weekly face-to-face service with our GP and advanced paramedic practitioner. We had written to the Home Office, and Ros and I sent a letter very many weeks ago now, seeking additional funding for an enhanced service to provide assessment of individuals, because what we're finding is that apart from the very first cohort, the usual medical screening and health assessment screening has not been done. And we therefore put in place a model with a nurse who's trained to do this, to provide that routine assessment and screening of things like infectious and communicable diseases, that is absolutely important in terms of the ongoing well-being of residents. We agreed as a health board that we would go at risk because we've still had no confirmation from the Home Office in terms of the resource around that. But it was suspended last week, just prior to starting, because we thought that we had a potential COVID case, which has fortunately proved negative. So we will hope to stand up that enhanced service of screening from this week. The other factor I would say again is that despite the continued discussions with the Home Office, we continue to have very, very little in the way of records of these residents. So again, we've had probably about 6% of the records for individuals coming onto the site, and we've currently got over 140 there to date. So that's something that's quite important in terms of the ongoing continuity of care. And one of the things that we've also asked, because that's not a static population, individuals are coming and going. We've also asked that we're made aware of those individuals as they leave the Penally camp and new ones come to Penally. So I think we continue to work together as a health board team and with our GMS team to register the individuals, to provide that ongoing care, and particularly for their acute care needs. And we will look to step up now that health screening service as soon as possible. But we continue to work with the Home Office and Clear Springs to ensure that both the security in transporting individuals both to and from South Pembrokeshire, and also things such as very practical issues around records, so that we can provide that ongoing continuity of care and made available to us. Thank you.
Thank you, Jill. I'm going to bring in Phil as well.
Thanks, and yeah, to reiterate Jill's point about the phenomenal effort of our staff, and also Jill and Ros' leadership in setting up both the risk assessments and advice around infection control arrangements, but also the health services that we've been able to put in at extremely short notice for the residents who've been placed there. I think Steve's point about that we've made about our feeling that the unsuitability of the site to be able to maintain security for infectious disease COVID being of particular concern, and our so far lack of assurance that all of those measures have been, or indeed may not be possible to put all those measures in place on that site to maintain security for if there was a case of COVID on the site. I think just the other additional point I was going to make was that all of those health services, the sort of core service and the additional offer that we put in for the residents on the site are within our expertise. I think have to recognise that we are not used to having a large group of asylum seekers in interacting with our services, and therefore there's also a risk around our expertise to be able to deal with the needs of the asylum seekers. But we're doing what we can, and we're connecting with as many experts as we can to provide the best offer we possibly can for those residents.
Thank you. If I could summarise, we have made extensive recommendations to make the site as COVID and infectious disease assured as is possible in the circumstances. We are not assured by the Home Office's response. We are not the regulator, so it's not our role to go on the site and keep checking. So we have referred our concerns also. I've shared them with Health Inspectorate Wales. I don't know what their remit is in respect of Crown property. We remain concerned about self-isolation before men who are seeking asylum are brought to the site. We're concerned about the isolation facilities on the site. As Jill set out, the health assessments. We are not an area with the expertise in Wales of asylum healthcare. We're not being financed for this. We are doing the very best we can to provide healthcare in our expertise to the men on the site and also to the surrounding community in Hywel Dda. Healthcare workers and Jill as the Director of Primary Community Care and Ross as Director of Public Health have done incredible and are doing incredible work in the middle of a pandemic. So I would be very grateful if, Anna, this could continue to be scrutinised at your committee. I do remain concerned about the risk on that site to the men and to the surrounding community, and as a health we don't believe it's a suitable site at all. So thank you.
Yes, we'll continue to monitor that through QTAC, Chair.
Thank you very much. I'm going to bring in Mandy, who wishes to make a comment on the COVID item within the report.
Thank you, Chair. I won't take many minutes. It's really just to flag the fact that this was the first of our re-stood up COVID extraordinary quality committees, and as a result of that, we actually did take a lessons learned to date from the COVID outbreak situation, and it's really just to flag and that every time we have an outbreak meeting, any learning that has come from any outbreak meeting or indeed from any national discussions are fed automatically into the next outbreak discussions. The other thing I would say is that obviously HIWs sit within our quality committee, and they commented that they found the report extremely helpful, and I have indicated that we will continue to provide these reports into our extraordinary COVID quality assurance committee, albeit it won't be in December, it will be for the next meeting, because obviously it's a rapid changing and learning landscape. The 16-point plan that has been issued from through Welsh Government is also being actively pursued and engaged. So it was just to note that we are continuing to focus around learning from each and every outbreak.
Thank you, Andy. Michael, did you want to come in?
No, I'm on the next item, so I just put my camera on as instructed.
Okay, thank you. So thank you for the report, Anna, and we're going to go now on to the Finance Committee. Michael.
Thank you, Chair. Apologies for the sun shining on my head. The sun shines on the righteous, as you know.
That's why we're all in the dark.
So there are a couple of reports in the agenda bundle which cover off our meetings on the 29th of September, where we talked about the month 5 position, and the 22nd of October, where we talked about the month 6 position. Period 7's on the agenda next. I think Hugh will cover off in his item. Nothing specific to report from either of those meetings. I would just take a moment just to say, in line with Joe's excellent work in streamlining the work of the committees, going forward, starting next week, which is our next meeting, we've streamlined the agenda for the Finance Committee to focus on 3 things. Making sure that we are monitoring the current in-year financial position to ensure we land the numbers in the right place, thinking about the financial plan for 21-22, and thirdly, thinking about our financial strategy to reach financial balance over the forthcoming years. And everything that goes around the Finance Committee will be focused on how do we achieve those 3 things. Nothing more to say, Chair. Happy to take questions.
Many thanks, Michael. That's really assuring. Any questions? No, many thanks. I'm going to go on to the financial report, month 7. Hugh?
Cadeirydd, diolch, thank you. So as Michael alluded to, the Finance Committee will be meeting next week to go through the month 7 position in more detail. So I probably won't look back that much. I just want to look and focus our time looking forward at the rest of this year. And clearly, it is a challenging year with a number of moving parts that we're actively managing. The year-to-date position is currently on track to deliver that forecast position of 25 million, which was in our plan at the start of the year. But those moving parts are causing us some challenges, not least because of the requirements for workforce, which is the biggest single driver to them. And indeed, if there's one thing that's going to stabilise the financial position, it's probably the challenges we've got in the availability of staffing. So that's one thing that we're keeping a very close eye on. There are a number of areas that I just want to draw to your attention where I've sought assurances from others to stabilise that forecast position. The first of which is ICF. Clearly, there's been slippage on a number of those schemes across the region, and I've received assurances from the West Wales Care Partnership around the expenditure plans for the rest of the year. We keep that under close review. Similarly, on cluster funds, where I've sought assurances from primary care and around expenditure plans. The other 2 significant elements then are firstly the adult social care funding stream from Welsh Government, and we're working with Welsh Government colleagues on how that will be spent in the second half of the year. And of course, the biggest single impact is on variable pay and the need to deploy staff over the rest of this year. Given all of those issues, I think at this stage there's probably around flexibility of about 4 million in our forecast, but there are also challenges that we're managing that largely absorb that 4 million. So if I look at urgent medical equipment replacement programme, some tax and legal issues that we're dealing with, the additional costs arising because of the work that we just talked about in Penally, and some of the winter plan pressures that we've got, and some other costs around EU exit costs as well. That broadly comes to around 4 million. So at this stage, the flexibility is more than addressed, or is certainly addressed by the challenges that we're also facing. What we've not got yet in our forecast position is the cost of the vaccination programme, and we're working through the implications of that, and we'll be in discussions with Welsh Government on funding for that over the next few weeks. So at this stage, the £25 million deficit forecast remains our financial forecast. Ongoing very close scrutiny of that, working very closely with colleagues in Welsh Government, and obviously we'll pick it up in the Finance Committee that's coming up as well. So with that, Chair, I'll open up to questions.
Thank you, Hugh. Any questions? Judith, would you like to ask a question?
No, I'm responding to the message to switch my camera on. Thank you.
I'll stop asking when I see people then. Any questions on the report? Okay, thank you. The board notes the financial position. Thank you, Hugh. Next is Judy, report of the Health and Safety Assurance Committee.
Yeah, thank you, Chair. The report is there for information and for any questions. I'd just like to highlight one issue in the main body of the report, and that's the first item, which is the Health and Safety Executive Enforcement Action Update. And really to just say that we did recognise and welcome the progress that's been made on this item. And I think paying tribute really to Mandy's leadership of this and the developments that have been within that team. I think my worry-ometer was quite high when we took this on, but it has come down significantly. So I think I did want the board to note that. There is still work to do, but we were much more assured that we are on track. In terms of the issues of concern, you'll see reference there to the fire safety audit system. This is a process that is not set down by us, but we were concerned that the findings of that didn't seem to align to issues that had come up in the fire safety governance review. So this is going to be discussed further and will be reported back to the committee. That's all I wanted to say. Thank you.
Thank you, Judith. That's good to hear. Going to bring in Mandy.
Yes, thank you, Chair, and thank you, Judith, for those kind words. I think the team are working incredibly hard, and it was just to provide further assurance that earlier this week we had a further meeting with the Health and Safety Executive, and they acknowledged the progress that we have been making, and I'm very optimistic that we will be receiving confirmation of closure of a number of the outstanding actions, and in fact subject to some further points of clarity that they've requested. I'm hoping that we will be in a much more positive position by the end of this calendar year. So it's just to provide further assurance that we're continuing to work on those actions.
Thank you, Mandy. That's really good news.
It is, and thank you. And I know the wobble factor or the worry factor that you allude to, Judith, when you kindly took this role on. So many thanks, and many thanks, Mandy, for your leadership in this area. Yeah, as Paul says in the message board, excellent news, well done. Any other questions of the committee chair? Okay, thanks everybody, and we'll go on to the next items of the agenda. It's the organ donation annual report. Do you have anything to add to this? Sorry, it's Andrew.
I'm sure Judith, having just taken over the chair of the organ donation board across the health board, may want to say a couple of words as well. But I think the report and the SBAR are fairly self-explanatory in terms of the content of the report. I think what I'd like to do really is firstly just thank Cathy Rumbelow and in particular Ria John for the work they've done in putting together the information to enable us to present this report to and for the board to receive this report today. As for much of the NHS, it's been a difficult year for the organ donation service and team, not least because of their own specialty area and the challenges they've had to overcome in delivering their service, but also for the way that they've, but also thank them for the way in which they've come to help other services and the critical care service in particular during the first wave of the pandemic, and are on standby should we need them to support our critical care staffing during the second wave. They've obviously, like many staff, have been deployed into different roles at various points during the last few months to help with the overall response. The report quite straightforwardly presents our performance against the priorities for the year. I think the biggest disappointment talking to the team was just they want to continually achieve an increasing rate of organ donors year on year, and obviously this year they've not been able to do that. There's a positive in that, because part of the reason is the lockdown and the reduced number of traumatic cases and injury that came through. So we've seen in that sense, we've seen an improvement in terms of our mortality rate for some areas, but it's obviously impacted on the transplant. That has a knock-on effect in terms of the transplant waiting list and people waiting for organs that can be donated. So I don't think there's much else for me to say other than ask the board to note the report.
Thank you, Andrew. Judith?
Yes, thank you. Would like to come in. I seem to have gathered up quite a number of these committees recently, but echo what Andrew said, but also just to recognise the work that Peter Skitt has done in chairing this committee over the last few years. Actually, he's done a tremendous work to keep this going. We are due to advertise after Christmas for new clinical leads for organ donation, or CLODs as they're lovingly called, and again we'll report back when we have done that. I think the other piece of work I'm keen to see we do is to really increase the amount of input to the committee from the families of donors and also the recipients of donations. We do have a very active member on the committee, but it would be really good to extend that. So that is again something to continue. But as Andrew said, the work of Ria in particular does need to be recognised. She does a sterling amount of work within the health board and linking into the network. Thank you.
Thank you, Judith. Do members have any questions or comments on the report? No. Thank you very much. And you can pass on our thanks from the board as well. Yeah, Derek is saying it's a really good idea to gather the views of families, absolutely. So that the board's happy to note the report. We're now going to go on to the committee update reports. I'm just in my computer. Yeah,
so item 6.1, Chair, covers the update reports from the Charitable Funds Committee, the Lasting Committee Board, the Healthcare Professionals Forum and the Stakeholder Reference Group. There is only one matter to raise to the board's attention from the Stakeholder Reference Group. If the chair of the group had wanted to add anything from that particular item. A couple of key risk areas for the board to be aware of, and they're detailed within the update reports and in the overarching SBAR, Chair.
Many thanks. Hazel, would you like to speak to that at all? Not sure.
I didn't have anything specific to raise, but if anybody has any questions, then I'd be more than happy to answer.
Thanks. Any questions on this? Okay, board happy to note all the update reports. Thank you. Then we've got the joint committees and the collaboratives update reports.
I'm happy to take any questions, Chair.
Thank you. Any questions on those reports? Okay, board's happy to receive them, thank you. Then we've got the statutory partnership update reports. We've got Ros and Jill here.
Yeah, if I may come in, I don't know if Ros wants to start on the PSBs, but I'd like to pick up the Regional Partnership Board, if I may.
Yes, of course.
So thank you. I just really again to draw attention to a number of items on the paper from page 2, and obviously we've acknowledged the new chair and vice chair appointments, but I particularly wanted to assure the board in terms of the discussion that we had previously in the meeting and reflected in the ARAC conversation. So board members can see that we did indeed take the ICF paper to our Regional Partnership Board for a quite comprehensive conversation really around the need to ensure that we have got appropriate governance in place around these joint funding arrangements, because the Regional Partnership Board is of course set up in statute but has no statutory responsibilities, and it's quite complex really in terms of how we ensure that we've got appropriate arrangements in place. So you can see from the report that the areas, the deficit areas, have absolutely been recognised, and we've agreed that there will be a quarterly meeting now to engage our governance colleagues in terms of putting in place a far more robust arrangement across our partnerships. And this was also recognised by all members of the Regional Partnership Board and our local authority partners in terms of supporting the way ahead. And the other item I just wanted to draw your attention to is the attachment that I've put there around our palliative care principles. palliative and end-of-life care is something that I've wanted to bring to the board for some time. I've picked up this portfolio probably over the last 6 months, and it's something we don't probably talk enough about. And it really has come into its own over the last few months, where we've really developed a far more integrated arrangement across our 3 counties. We've recently had a Welsh Government review in terms of the 10-year review of the sugar report, and we're waiting for that final report to come back. But we are also tendering and have just tendered for some work to undertake a stock take of our services across the 3 counties. Historically, we've got quite different positions, but we have seen over the last few months a real sense of integration across Hywel Dda. And the setting of these principles, I think, brings us together with a set of principles that we wanted to confirm are in place now. We've taken to the Regional Partnership Board, and we would recommend them to our board today, really, in terms of making sure that we've got equity of outcomes right across our 3 counties. And this is such an important time. And as I say, we've seen a real coming together of consultants, lead nurses and others who support our integrated services in palliative and end-of-life care. And it's just something, when we get into more normal boards, I'm sure I'd like to do a patient or relative story, really, in terms of some of the work that our palliative care teams are doing. So thank you.
Thank you, Jill, and that's really, really important, and thank you for bringing that to the board. And we would like to hear from a patient or a family story, or even a staff story. It is one of the most important services that we provide, and it lives with people forever, those loved ones who remain. So thank you. Any questions on this? Ros, do you want to come in at all? Don't feel you have to.
No, thank. So, as the report from the partnership, the PSB perspective, thanks.
Thank you. Are there any questions from board members at all? Okay, thank you. We know the report, and thank you very much for that. I'm going to go on now to the Community Health Council annual report. Mansell, is there anything you'd like to add to this? Okay, right. If there are any questions, then Donna will be able to take them. Not at the moment, but I'm sure if we wish to raise any issues, we'll do them in our regular meetings. So the board's happy to note that report. Thank you very much. Next is the Health Inspectorate Wales annual report. Are the board happy? Are there any issues the board wish to raise on that?
And just to flag, Chair, we did discuss in the board seminar, and there's the detailed update within your report for assurance purposes.
Thank you. Okay, board's happy to note that. And then the board work programme. Board happy to note that. Thank you. Well, that is the end of our open board meeting. I just want to also reassure members of the public that since the onset of this pandemic, the independent members have been meeting weekly with the Chief Executive and I. So we've all been very well informed and have the ability to influence, scrutinise and understand all the challenges that have been and are ongoing, and we will continue to do that. And the independent members and I also meet before board so we can scrutinise together the board papers. So although this meeting may be quite short, there has been a lot of scrutiny and questions and discussions outside of it. So thank you very much, everybody, and we'll see you at the next board meeting. So I formally close this board meeting, and in 5 minutes' time we'll go into our brief in-committee session. Diolch yn fawr iawn, thank you.